Good afternoon and welcome. I'm Nora Kane. I'm the director of the Stanford Health Library, and it's my pleasure to be welcoming you to one of our community lectures that ordinarily take place in the Health Library, but in these COVID-19 days, they're taking place in everyone's living rooms, wherever you are, and that includes Dr. Huddleston, our speaker today, as well as myself. I have to add another note because we're in California and we're in the midst of a terrific heat wave. We've been receiving little alerts that say that we might lose power. So if for some reason your screen goes black and everything is gone from this end, please understand that we probably have lost power at some one of the places from where we're broadcasting, and we will make it up to you. We'll post another time that we'll do this talk again, but I just wanted to give you fair warning, especially if you're new to Zoom. It might feel like you did something. And don't worry, it's just the power outages that might come with us this afternoon. Today's talk is given today by Dr. James Huddleston, who's an associate professor of orthopedic surgery here at Stanford. Dr. Huddleston has spoken for the Health Library before, and it's always great to have him. He brings a wealth of information and updated news about joint replacement. His clinical focus is on hip and knee replacement surgery and also on hip and knee replacement revision surgery. So he's really quite the person to hear talk about this. And so we're excited to welcome him back today. And without any further ado, I will be turning it over to Dr. Huddleston. If you have a question, feel free to type in your question down below at the participants chat bar. So thanks very much, Dr. Huddleston.
Thanks very much, Nora. And welcome to everybody who has tuned in. It's a pleasure to be with you this afternoon. I will give you a update on a topic for hip replacement, which is something that is controversial at the moment, and that is the surgical approach that surgeons prefer to use to do your hip replacement. I'm happy to take any questions. We will save them for the end of the presentation. So what surgical approach should I use? Separating the evidence from the hype. These are three of the pioneers of hip surgery, all of whom have a different approach named after him. This is Marius Smith-Peterson, who's considered one of the pioneers of the anterior approach for a hip replacement. That's from the front. This is Sir Reginald Watson-Jones, who's credited with popularizing a version of the lateral approach. And then this is Dr. Moore, who's credited with popularizing what he termed the southern approach, which is essentially a posterior approach, which is coming in more from the back or the side of your hip closest to your backside. So these are my disclosures. None of them are relevant to this discussion this afternoon, and I will disclose the fact that my preferred approach for a hip replacement is a posterior approach. So to summarize things, there really isn't a perfect approach to the hip joint. You know, the perfect approach wouldn't cause much pain. It wouldn't have any complications associated with it, and everybody would do great. And that's really not realistic in most surgical disciplines, and certainly not realistic in hip replacement surgery. So every approach has its pros and cons, and my job here over the next 40 minutes or so will be to help shed some light on those pros and cons and let you all make your own decisions. But I will make the claim that modern approaches have good durable results, and it's important that the surgeon shouldn't let the approach compromise the success of an operation. As some of you may know, total hip arthroplasty is arguably one of the most effective medical interventions of all time. And with such high success rates, we would not advocate a different approach if it's going to have a significantly higher chance of having a problem, especially in the setting of an operation that works very well. So these are the issues that the surgeons would like to consider when they're trying to select what approach they're going to use. So I'm going to generally group the surgical approaches for hip replacement surgery into three. So there's what we refer to as the direct anterior, that's coming from the front. The lateral would be more coming from the side of your hip joint, and there are various permutations of that. And then a posterior approach would be coming more from the back side. even though the incision is not quite on the backside, you are coming from the backside of your thigh bone. So those are the three general groups. So these are really the issues, and I will summarize this for you so that you have a good handle on it before we get into the weeds. But in terms of the anterior approach, there's definitely renewed enthusiasm for this. There was interest for this, especially in France in the late 40s and 50s with the Judet brothers. They abandoned trying to do hip replacements from the front because it was fairly difficult. But with some new techniques and new instruments, the anterior approach has certainly become a safe and viable approach. And proponents of it will tell you that there's a very low dislocation rate. The recovery might be a little bit faster than other approaches. And there's no question it's been heavily marketed to patients quite successfully. The downsides would be that it's probably a little bit more difficult than the other approaches for a variety of reasons. And thus the learning curve, or the amount of time that it takes for the surgeon to get facile with it, may be a little bit longer than other approaches. Many folks who use a direct anterior approach will have to have a special operating room table. That adds some expense and also fiddle factor to it. There's a nerve in your skin called the lateral femoral cutaneous nerve that can be damaged in the anterior approach. That's not an issue with the lateral or the posterior approach. If you needed to get more exposure, i.e. if you had to address a fracture of the bone, that fortunately doesn't occur very often, but it does occur. It's difficult to do that when you have an anterior approach. It's much easier when you have a lateral or a posterior approach. For the most part in the United States, most of our hip replacements are done with what we call a cementless device. So the implant has a porous coating on it, and the bone grows into that, and that's what stabilizes it to your skeleton. That's called osseo, and osseo is bone, and integration. So that's osseointegration. Historically, hip replacements were done with bone cement, and we certainly still use bone cement regularly. It's just not very common to do. And so one of the things that we've seen with an anterior approach is a higher chance that the thigh piece won't have the bone grow into it. And where I work is a tertiary referral center, meaning I see many of the hip and knee replacements that didn't work out for a variety of reasons, and these can be short-term failures or long-term failures. But we saw a rash of cases where the bone didn't actually grow into the femoral prosthesis and it had to be redone. So that was an unusual failure mechanism. And then there are some more recent reports of higher infection rates with an anterior approach. And the reasons for that are likely multiple, but a little bit of a longer operation with an anterior approach making for a higher infection rate. And then the skin in that part of your body isn't necessarily as reliable and healing as it would be with a posterior or lateral approach. So I can't prove you that, but those are offered explanations. So that's sort of the pro and con situation for the anterior approach. For the lateral approach, and there's anterior lateral, direct lateral, and transtrochanteric, and they're not all the same, but for the purposes of discussion, we'll group them the same today. This definitely has a low dislocation rate. However, it's been noted the patients who have a lateral approach may limp for longer after the operation. And if you do one variant of a lateral approach, which is a transtrochanteric approach, that's essentially cutting the bone to gain exposure. That bone doesn't always heal. It does reliably the vast majority of the time, but occasionally it doesn't, and that introduces another failure mechanism to the operation that wouldn't be present in other approaches. And then lastly, the posterior approach is still the most commonly used approach worldwide, and certainly here in the United States, though the anterior approach is gaining in popularity. And the posterior approach is familiar to many surgeons, and it is indeed extensile, meaning if we're unlucky and get a fracture of your femur or thigh bone or of your hip socket called your acetabulum, it's easily addressed through that incision. And then there is historically a bit of a higher dislocation rate and maybe a shortly higher recovery rate with the posterior approach. So that's certainly been challenged, and I'll take you through some of the studies looking at that in greater detail in a minute. So those are the details that I want you to consider. And we're just going to go through every factor that one would consider, both the surgeon and the patient, and even the hospital or hospital system, in terms of what approach they think one would use. So I talked about marketing of the anterior approach. That's something that's well established. And this was essentially a survey of patients in 2017 from the Mayo Clinic in Rochester, Minnesota. And they had data on 168 new hip patients. And most of them hadn't heard of an anterior approach to the hip. They stated that they got most of their information about hip arthritis and hip replacement and the various permutations based on information from family and friends. Most of the patients were actually unaware of any actual data looking at different approaches. And they did report that their perceptions were heavily influenced by marketing, which is not any surprise. This is a systematic review of the literature. So a systematic review is where we will take different studies and we'll take the raw data that went into those studies and pool the data and then try to do a separate statistical analysis on that. And the more observations you have something, the more likely you are to accurately pick up any differences if they are there, or pick up no differences if that's actually the case. So pooling data together increases the chance that you'll be able to make some meaningful conclusions. So this is considered one of the highest levels of evidence. It's similar to what we call a meta-analysis, which is a similar analysis in principle anyways. And this is basically looking at the direct anterior approach in total hip arthroplasty. And this graph here, you can see the studies that were used here on the left. And then this graph just looks at the time of the operation, and the blue bars are the anterior approach and the posterior approach is the red bars. So you can see, for the most part, the direct anterior operations took a little bit longer. We all want as short of an operation as possible because a longer operation confers an increased rate of infection, and it also likely is a marker that you're going to have increased blood loss because the operation took longer, and that may increase the blood transfusion rate, which fortunately we have at almost zero today in 2020. That wasn't how things were 10 and 15 years ago, but the operative time in terms of blood loss is less of an issue now in terms of blood transfusions than it used to be. But the infection rate with a longer operation is a real thing for sure. So we want the shortest operation as possible. But so this was from the Bone and Joint Journal, which is one of our most respected medical journals for orthopedics. And the take-home message from this systematic review was that to date, there's no real evidence that the direct anterior approach of the hip represents a better approach compared with the lateral or posterior approaches when performing a total hip arthroplasty or total hip replacement. Those are synonymous. So that is from one of our main journals, and that was from 2017. But I will tell you that it's safe to say that not much has changed with regard to their recommendations. So let's just go over a couple things that we would look at to see what kind of approach we want to do. So I think everybody would agree that it's really crucial with your surgical approach that you can see what you need to see so that you can put the implants in the right position. This is an operation that's supposed to have a 90+% chance of lasting 20 years. And that is really predicated on getting the implants in the right position and doing so in a timely fashion while taking very gentle care of one's soft tissue, so to speak. So you got to be able to get the parts in the right place. And with an anterior approach, many of the surgeons will use a tool called fluoroscopy, which is essentially a portable x-ray machine. And it allows you to take x-rays in 2 different planes very quickly. So that'll give you a nice assessment of how the implant looks and what position it is. Fluoroscopy is not routinely used in a posterior approach or a lateral approach. And so if you use fluoroscopy, you're kind of cheating to some extent, although it's probably a good cheating, but that allows you to put the implants right where you think you are. And fluoroscopy is accurate for the most part. So with fluoroscopy, as you'd expect, the implant positioning is going to be a little bit more accurate. Now, whether that makes a difference to the patients or not, I don't think anybody can say definitively, but you would like it to get it in the best position. And there's no question that the anterior approach, specifically with fluoroscopy, is going to confer an additional benefit here. So what about some other folk studies? So this was looking at what would be the predictors of the implants not being put in the right position. And the consequence of the implants not being put in the right position are multiple. So they could be a discrepancy of how long your leg is. Your implant may be in a position that causes your hip to dislocate, which is obviously a major problem. And there's several other things that could happen if the implants aren't in the right position. But dislocation, or the hip popping out of the socket, and appreciating your leg being a different length than what it was supposed to be, are two of the big ones. But in this study from Washington University in St. Louis, the predictors of the implants not going in the right position would be patients who had a high body mass index, more soft tissue that the surgeon has to go through to get to your hip joint, makes the operation a little harder, and that's probably why the implants aren't always in the optimal position then. And then the more operations you do, just like anything else, probably the better you are. So if you didn't do as many operations, you had a higher chance of the implants not being in the optimal position. And then if you use an anterolateral approach, at least in this series, that was a risk factor for implant malposition. And this graph right here really depicts what we mean by implant malposition. So there's essentially two different angles that we look at to make sure that the hip socket implant is in the right position. And that's abduction, which is here on the vertical axis, and on the horizontal axis is anteversion. And so there's a range that we think is acceptable for patients, and it's in this box. So you'd like to see every blue point, which is the actual data, within this box, and you can see there's a lot that are out of this box. Now, just because you're out of the box doesn't mean that you're going to have a problem, but we know you have less of a chance of having a problem if you're in the box. And that concept has been challenged now with some things that are beyond the scope of this lecture, but historically that's what the dogma has been. So here's a patient from Massachusetts General. That's where I did my training. And this won an award for a group of folks we call the Hip Society. And they basically looked at the same thing, comparing risk factors for acetabular or cup malposition. And again, if you had an anterior lateral approach compared to a posterior lateral approach, you had a higher chance of malposition. Same thing for direct lateral. If you had so-called minimally invasive surgery, that was a higher chance of having a problem with implant malposition. And then they found the same thing with surgical volume. If you were considered low surgical volume, your chance of malposition was greater, so no surprises there. And then this is a study from our institution that we did using my patients who we used the posterior approach for, and my partner, Michael Bellino's patients, who we use as an anterior approach. And we looked at the effect of intraoperative fluoroscopy on limb length and then precision of positioning the socket in the right position. In terms of the socket positioning, there really wasn't any difference between Dr. Bellino's patients and my patients. However, in terms of length of the limb, the means of what that discrepancy was between the two legs was not any different. But in the posterior approach patients, there were some patients whose leg was on the extreme end of lengthening to the point where they may have noticed it. Now, these are my patients, and I know they weren't symptomatic from it, but it's something that we can measure on X-ray, and obviously we'd like there not to be a difference, or at least hope that that difference doesn't get picked up by the patient, and they did it in this patient. They did not in these patients, but in terms of the statistical analysis, this was a factor. So this favors the anterior approach a bit. This is a multi-center study that is from the United States and Europe. It was run by Mass General. We're still doing part of it, but we have garnered a lot of data from it and learned a lot from the patients. And we did a similar analysis comparing patients who had an anterior approach. There was 205 of them. Those who had a lateral approach, there was 315. And a posterior approach was roughly half of the cohort of 1,000 patients. And these are the numbers right here of the success of the surgeon putting the socket in that desired window again. And so that happened 82% of the time for an anterior approach, 57% of the time for a lateral approach, and 73% of the time for the posterior approach. And there were no differences statistically for limb length discrepancy in terms of the mean values or outliers defined here as those greater than 1 centimeter difference. These are data from a surgeon named Jose Rodriguez, who works in Manhattan, and he describes his transition from a posterior approach to an anterior approach and how he did with socket positioning. And I'll share those graphs with you in a minute, but this table basically just shows that the patients, in terms of their age, their sex, their BMI, and their diagnosis, they were all the same. So there were no biases in terms of patient selection there, which is always good for the validity of the study and the conclusions that can be drawn. And then these plots here show you the acetabular position, again, trying to get it into a window. So if you just look at this from 30,000 feet, you want to see the dots being as close together as possible. And as you can see here, so A was his posterior approach set of patients, and you can see this is a fairly wide spread. And then here is his first 50 patients who he transitioned to the anterior approach. So a little bit of a narrower spread. And remember, this is what we expect because you're using fluoroscopy to take a look at where the socket is, and you can make some fine tuning within the operation to get it in the target zone. And then this is after he did his first 50 cases, which were defined as the learning curve cases. You can see that he has a nice tight scatter plot here. So in terms of socket positioning, this shows very good results with the anterior approach. Now the question is, does this affect the clinical outcome at all? And sometimes it does, sometimes it doesn't, but it's by no means a direct correlation. And then I talked about that skin nerve that can get damaged when you have an anterior approach. This would not be an issue for the lateral approach or the posterior approach. So this is a series out of Paul Boulet's practice. And he basically looked at 132 patients who he did a total hip arthroplasty on, or a surface replacement on, that's a variation of a hip replacement. He found that 107 out of 132 of his patients had some symptoms related to the lateral femoral cutaneous nerve being damaged. Now, most of the time that's just numbness, but it definitely is pain in some of those patients. And that's what you don't want to have, is people having pain in that distribution because the nerve was stretched during the operation. And unfortunately, 88% of the patients had symptoms at 1 year post-op, and only 3 patients had complete resolution of their symptoms. So this is something that is not ideal, and it's usually minor like numbness, but as I said, it can present as pain, which can be very debilitating. So if you didn't have to have this be part of the equation, that would be great. And as I said, this is part of the equation for an anterior approach, but not a lateral or a posterior approach. So in terms of cost, I would say that the winner is undecided. There are many things that go into determining costs. So if you have to buy a special table to do an anterior approach, that's going to add some costs. Some of those tables can be on the order of $100,000. The use of fluoroscopy takes time from a trained tech. That adds expense. And then a little bit longer operation is going to add some expense in terms of operating room time. And then areas of savings could be, if you can get the patients out of the hospital earlier, that will save some money to the system. And then if you can have more patients go home rather than go to a skilled nursing facility after the operation, that would save quite a bit of money as well. We referred to that decision as the decision whether or not to use post-acute services. So post-acute is basically after you've left the hospital, and that can be a true rehab hospital, which is very close to what we consider a regular hospital. It can be a skilled nursing facility where you're going to have less care there than an acute rehab hospital, or it can be a nurse and a physical therapist coming into your house. Those are the real 3 main options here. So this is a study from Mulligan looking at the financial impact comparing anterior versus posterior approaches. And I won't bore you with all the data. But what I will say is the cost is essentially a wash. So if you look at total costs, and costs in a hospital environment, because of the complexity of it, can be difficult to capture accurately. On average, I shouldn't say average, it's a median, not an average. So half are above and half below this number, but the anterior approach median patients, the cost was $19,704. And the posterior approach was a little less, $17,904. So that's an $1,800 saving. That's pretty good. But what we're really interested in is in fine tuning and not necessarily looking at indirect costs. So if you do a little bit of more granular dive, taking direct costs minus operating room supplies, implants, and pharmacy costs, then the anterior approach patients were $580 cheaper for the episode of care. So in terms of cost, I'd say that there's not a clear winner. This is a study that didn't get published, but it was presented at one of our main national meetings. It's called the American Association of Hip and Knee Surgeons. And we have an annual meeting every November in Dallas, and this is from the 2015 meeting. And this is comparing 21,000 patients who had a posterior approach and 2,800 patients who had a direct anterior approach. And remember, I told you that the use of post-acute services after the operation, when somebody leaves the hospital, is a significant driver of the overall cost of the episode, which we essentially define as from when the operation happens to 90 days after the operation. And so if you can have fewer people using post-acute care services, that's going to infer cost savings. So those post-acute care services, the most expensive would be a rehab hospital. Most of our primary hip replacement patients don't qualify for a rehab hospital, so that's not really part of the discussion. But they're either going to go to a skilled nursing facility or go home. So if you can get more patients going home, that's going to save money. In this study, though the groups were kind of uneven in the number of patients they had, there were no differences in the number of patients who had to go to a skilled nursing facility between the two approaches. And the readmission rates were a little bit higher for the direct anterior approach, but maybe not clinically significantly higher. The conclusions of the study was that the surgical approach was not a primary driver of utilization of post-acute services. So that basically ramifies the fact that cost is probably a wash between direct anterior and posterior. So what about operative time and estimated blood loss? These kind of go together. But if the operation takes longer, most of the time there's going to be more blood loss. And as I said, most of the studies show that the anterior approach can take a bit longer than a posterior approach. Now, that's certainly not true for everybody, but this is a good prospective randomized clinical trial comparing direct anterior and posterior, and they showed increased operative time and increased blood loss with a anterior approach compared to the posterior approach. So in terms of how long the operation takes and blood loss, the winners would be the posterior and lateral approaches. And remember, longer operation for an increased chance of infection, which is a dreaded complication. In terms of recovery time, I think the winner is the anterior approach. The data are a bit mixed, and I think when patients ask me about this, what I tell them is that you may get better a week or two faster with an anterior approach, but by 6 weeks, that difference is gone. And certainly at 1 year, that difference is gone. So the recovery time issue is probably overblown a little bit. And unfortunately, we're getting to the point now where we're seeing patients who are too active after the operation and the bone doesn't grow into their thigh piece, probably related to how active they are, and then they need another operation. So that's really moving in the wrong direction. So it is possible to tell patients to recover too quickly and to have a problem associated with it. And we've seen it multiple times in our clinic. So this is one of the earlier studies comparing anterior approach versus a posterior approach. This is a randomized controlled trial between two surgeons. It's hard to do randomized controlled trials with surgeons and hip and knee replacements because patients most of the time have a strong preference of their surgeon, which is certainly understandable. But anyways, this is 54 patients, and they looked at some evaluation scores post-op that are specific to the hip and then also to a patient's general health. And they reported that the time to ambulation without assistive devices was on average 22 days for those patients who had an anterior approach and 28 days for those who had a posterior approach. So that's favoring the anterior approach by about 6 days. Interestingly, SF stands for short form. That's the name of the outcome questionnaire. But looking at folks' mental scores at 3 weeks, there was a slight improvement for those with a posterior approach compared to an anterior approach. That's a statistically significant difference, meaning it is a real difference, but the difference is small enough that it's probably not relevant clinically, meaning the patients probably don't notice it. And then the surgeons concluded that, you know, neither one of us are going to change our approach based on these data. All right, these are data from Jose Rodriguez, again in Manhattan, and a gentleman named Amar Ranawat. This is from the Hospital of Special Surgery, amongst others. And they looked at patients who had a direct anterior approach and compared it to a posterior approach. And when they evaluated the patients pre-op to see if they were similar, indeed the patients were similar. This is a tug test, is a timed up and go. So it's basically how long does it take you to get up out of a chair and walk for 10 feet. And then this is a functional score, the MFIM. The HHS is called the Harris Hip Score. That's a hip-specific outcome, which is judged by the surgeon primarily, with some input from the patient. This is an activity score. And then these two short form 12 PCS is physical component score. So this is a functional score. And then this is a mental component score. That's an evaluation of their mental status. So before the operation, the two patient groups were very similar. So that's ideal. So looking at milestones in hospital. So in terms of time to walk 150 feet, the patients with the direct anterior approach did it a few hours sooner, and time to be able to transfer from your bed to your chair, vice versa. Again, this was slightly favoring the direct anterior approach, but by hours, not necessarily days, and the same thing for time to stairs. So these are patients in the hospital, and it appeared that the direct anterior approach patients were able to get around a little bit easier. And then if you look at 2 weeks, for the most part, other than the timed up and go test, there were no differences. Some of these are close to reaching statistical significance, but again, they're very small difference, 3.2 and 3.6 for an activity score, and then 2-second difference in the time up and go test. So this number here is statistically significant. These two differences here are nearly statistically significant. It's what we call a trend, but it's not truly a difference. So this is a difference, but by 2 weeks, it's really probably not clinically significant at all. So slight improvement in the hospital with the anterior approach patients, but by the time you get to 2 weeks after the operation, no real difference. And then by the time you get to 6 weeks, definitely no difference based on statistics. And then in terms of overall recovery milestones, time to discontinuing gait aids, transferring, discontinuing pain medicine, driving, return to work. Basically, there were no difference between the two groups. And as you might expect for the general health outcome measures, there were no differences at 6 weeks, 12 weeks, and 1 year. So overall, slight improvement while in the hospital for mobility for the anterior approach patients, but that difference is essentially gone by 2 weeks and definitely gone by 6 weeks. And in terms of major recovery milestones, no difference at any time between the anterior approach patients and the posterior approach patients. This is a study from a gentleman named Jay Parvizi, who works in Philadelphia at the Rothman Institution. And he looked at direct anterior approach compared to a lateral approach. The variables they looked at were operative time, estimated blood loss, how much your blood count went down, and then how long the patient stayed in the hospital. And between the two approaches, they didn't see any differences at all. And then lastly, in terms of recovery, this is a nice study out of China. And they looked at implant positioning here, which didn't tell us really anything new. Then they looked at some blood tests. Okay, so these blood tests here, the C-reactive protein, IL-1/6, and ESR, these are all general markers of inflammation in the body. And so they were getting at trying to see if you could make the claim that there's actually more tissue damage with the posterior approach compared to an anterior approach. The CK, which is creatinine kinase, is also an indication of that. And there were slight differences in the IL-6 levels favoring patients in the direct anterior approach, both on postoperative day number 1 and postoperative day number 2. But by postoperative day number 3, those differences were gone. And then in terms of the other markers, ESR, C-reactive protein, and creatinine kinase levels, there were no differences. So I would interpret these data to show that there's no more tissue damage done with the posterior approach compared to an anterior approach. In terms of the functional recovery, at 3 months, the direct anterior approach patients were a little bit more active and had a little bit of a higher hip-specific function score, though not terribly so. This study, I'd say, mostly shows no difference. Slight functional recovery improvement at 3 months, statistically significant, but not necessarily clinically significant, meaning the patients may not notice it. All right, and then I told you about patients having too rapid a recovery. So what I'm going to tell you here, so this is a patient that I operated on with a hip replacement. For the bone to be able to grow into the prosthesis, you need to have very little motion between the implant and the bone. And if you have more motion between the implant and the bone than is suitable, you're not going to have the bone actually grow into it, and you get fibrous tissue like the grizzle and roast beef growing into it. And then the implant isn't originally fixed, and then the operation needs to be done again. And this gentleman was in his 40s when he had his hip replacement, and he is quite active. And this is the day after the operation, him walking into his home. You can see he's walking fairly well, still has a little bit limp, but this isn't the average hip replacement patient. My point in showing you this is this gentleman is very active, and with the posterior approach, he was able to walk like that on post-op day number 1. And here he is water skiing at 6 weeks after the operation. And so this worked for him. But as I said, there are patients that are too active too soon, and they don't have the bone grown into the prosthesis, and then we have to redo it. So these are 2 different patients who were referred to me. And these are the plain x-rays, and then these are the bone scans. And the bone scans will take up the radio tracer that we inject in areas where the bone is active. So in a hip implant where the bone's grown into it, it should be a steady state, so to speak. So you shouldn't see any increased uptake of the tracer, meaning the bone around the implant should be quiescent and not really doing anything because there's no abnormal stresses on it. However, if the implant hasn't had the bone grow into it, then it should be showing metabolic activity, and that's what we see here on these 2 bone scans. And these are x-rays of implants where the bone unfortunately has not grown into the prosthesis. And both of these patients were told by the surgeon that they didn't need to use a walker or a cane after the operation. They didn't have any restrictions. And this is where they were at about 6 months to a year post-op. So this is not something that we saw when patients were slowed down intentionally after the operations. When they originally introduced cementless fixation on the femoral side, the patients had limited weight bearing for 6 to 12 weeks and were on gait aids for that long to try to get the implant to have the bone grow into it. So there's no question that the pendulum has swung a little bit too far, with surgeons telling patients that they shouldn't have any restrictions, because we're seeing things like this. And really active patients, I think, regardless of your surgical approach, I attempt to slow them down a little bit so that this can happen. You get one good bite at the apple here. And though these problems were fixable, revision surgery has a higher rate of complications compared to primary surgery. So we definitely don't want to have to do a revision surgery if we don't have to. So in terms of dislocation or the hip popping out of the socket, there's no question that the anterior and lateral approaches have a little bit lower of a dislocation rate than the posterior approach. We hear patients coming in saying they've been told that patients who have an anterior approach don't dislocate. That's definitely not the case. We've seen multiple patients with anterior approaches dislocate who come to see us in clinic. Not many, but certainly some, so it does happen. So this is more for historical purposes. This is an analysis out of Canada, and it's from 2004. And these are the sort of historic dislocation rates for various approaches. So this was 13,000 hip replacements and up to 30 years follow-up of these patients. And the overall dislocation rate was just over 3% for the posterior approach. A lateral approach would be somewhere between 0.72 and 1.46. So with modern implants, in surgical techniques, the posterior approach dislocation rate at this point is between 0.8 and 1%. So that's significantly lower than it was in these patients when we had fewer implant options to really fine-tune the mechanics of the hip and get things with the optimal geometry. So current posterior hip dislocation rate is about 0.8 to 1%, depending on who you read. So these are data from the Dutch registry. And it's looking at posterior approach compared to anterior and anterolateral approaches. And what they concluded, so this is a very large number of patients, it's 166,000. And what they showed was that patients who had an anterior approach or an anterolateral approach had a lower rate of dislocation compared to the posterior lateral approach, but that came at the cost of more stem and other revisions. So things like the bone not growing into the femoral prosthesis, that would be a reason why you'd have to do a revision. So a little bit lower dislocation risk with the anterior and anterolateral approaches in 166,000 patients, but that came at a cost at a higher chance of having a revision with those approaches, so that's not a good thing. And then the bigger ball you put on, which we refer to as the femoral head, generally the dislocation rate will be lower, and that's what they saw. And then this is from the Michigan Arthroplasty Register, which is spearheaded by a surgeon named Brian Huddleston, and they reported on 2,000 matched pairs of patients. So they matched patients basically same age, same sex, same body mass index to each other, those patients who had an anterior approach and those who had a posterior approach, and that's to minimize any differences in the patients that are inherent before they even have their operation. And what they found was that in terms of the dislocation rate, it was 0.4% for the direct anterior approach patients and 0.4% for the posterior approach patients. So essentially no difference in dislocation whether you had a posterior approach versus an anterior approach in a modern series of patients. They did see the operation taking longer in the direct anterior patients, so 101 plus or minus 38 minutes for those who had a direct anterior approach compared to 76 minutes for a posterior approach. But they didn't see any differences in terms of the fracture rate, estimated blood loss during the operation, formation of a blood clot in the surgical site after the operation, having to be readmitted to the hospital after you were initially discharged, as well as the time that you spent in the hospital. All right, what about this failure of osseointegration that I told you about? Some of this is related to surgical techniques, some of it is related to patient factors, and then what about the rate of having the bone actually break during the operation? And there's no question that the posterior approach compared to the lateral and anterior approach is the winner here. So this is a comparison by Joel Mata, who's considered really to be the one who popularized the anterior approach. This basically shows the early complication rate of 5,000 cases. The fracture rate should be low, and it is here. So there's a total of 48 fractures that occurred either during or directly after the operation, and that's basically 0.9% of the time, that some would say is fairly high, but overall I think with this number of patients it's acceptable, and it's certainly lower now that more people are becoming more facile with an anterior approach. And then these are two studies. One is out of our institution, and the other one is from a multi-center group on the East Coast. And this basically, these are two studies documenting the need for revision hip replacement for those patients with an anterior approach who had their thigh piece not have the bone grow into it. And that's not something that we see very commonly with posterior approach. It's seen more commonly with the anterior approach. All right, and then these are data from the Norwegian registry, and this is 21,000 patients from 2008 to 2013. And no real difference in terms of how long the implants would last, out to 8 years. But when they looked at specific complications, so for infection, needing to have another operation, the posterior and anterolateral approaches had a little bit lower chance of having an infection compared to the direct lateral. There was a higher dislocation rate in the posterior approach compared to the anterior group or the lateral group. So this has been shown before, but this is now from the Norwegian registry, looking at patients between 2008 and 2013. And then the most recent data comes from New York University. And the first author here, Vinay Agarwal, was our fellow here at Stanford 2 years ago, but he did his residency at New York University, and that's where he's working now. But they reported basically that surgical approach significantly affects the complication rates associated with total hip arthroplasty. So it's not a large group of patients. So it's 248 patients. and they suffered 263 complications. So you had about a 7% chance of having any complication. Some of these are minor, like a urinary tract infection. Some of them are major, like a fracture or a dislocation. So overall, patients who had the direct anterior approach had an 8.5% chance of having a complication, and the posterior approach had the lowest at 5.8%. And most of these were due to infection and fracture. And then the rate of dislocation was 0.84 for the posterior approach, and it was actually higher for the anterior approach, 1.28. So those data really favor the posterior approach compared to the anterior approach. And this is an award-winning paper, which is the same group of investigators. It's a sub-analysis just looking at periprosthetic infection between the two approaches. And basically what they found that the infection rate for patients who had a direct anterior approach was 1.22%. And this is out of 1,985 patients who had an anterior approach and just over 4,000 patients who had a posterior approach or a lateral approach. And then the infection rate in patients who didn't have an anterior approach was 0.63%. So that's roughly half. So this is essentially double the infection rate in patients who had an anterior approach compared to those who did not. So this would certainly favor the posterior approach or lateral approach over the anterior approach. And then what about patient-reported outcomes? So these are questionnaires that patients fill out to tell us how they're doing. They are useful for a variety of reasons. One of them is to see how well the implants are positioning. The other one could be a comparison of techniques. And I would say based on all of the patient-reported outcomes, there's no clear winner in terms of anterior, lateral, or posterior approaches. So these are data from Dartmouth, and it's Ivan Tomic, who's the surgeon. And you can see here in terms of this activity score, no real difference for patients who had an anterior approach or a posterior approach, and this is true for before the operation. 1 month, maybe a little bit of difference, but not much of a difference at 3 months or a year. And then when you look at a more generic score in terms of their physical function, mental function, actually the patients in the posterior approach had higher scores initially. Reasons for that are unclear. But if you looked at the physical scores, this favored the anterior approach. They were a little bit more active to begin with before the operation. That has a significant impact on how they will perform after the operation. But at 1 month, the anterior approach patients were a bit more active, but by 1 year, that difference went away. So this favors the anterior approach a bit, probably. And then these are data from my senior partner, Stuart Goodman, and my former partner, David Sherman, who's no longer with us, but they compared the posterior approach to the direct lateral approach, and basically they found no differences in terms of how well the hip functioned from a Harris hip score at 2 years after the operation, or rates of bone forming around the hip due to the trauma of the operation. So no difference there. And then in terms of the Swedish Registry, which is one of the most robust hip registries, this is a report on 42,000 patients, and they compared the lateral approach to the posterior approach. And they had just over 4,000 patients who had all of their questionnaires completed out to 6 years after the operation. And what they found is in the posterior approach patients, they reported less pain, higher satisfaction rates, and higher EQ5D scores. EQ5D is a generic health score. So these patient-reported outcomes favored a posterior approach over a lateral approach. And then this is a paper that we wrote through our multi-center research cohort that is spearheaded by Mass General. I've shown you some of the data from this study already. But these are now looking at the patient-reported outcomes. Lastly, we looked at what were the socket position. This is now looking at the patient-reported outcomes. And the title pretty much says it all. It says, no evidence for higher patient-reported outcomes after hip replacement with direct anterior approach compared to any other approaches at 6 weeks after the operation all the way to 5 years of a follow-up. And just to let you know how competitive it is to win this clinical research award, the American Association of Hip and Knee Surgeons annual meeting at this point gets between 1,500 and 2,000 different studies submitted to it. And of those studies, several hundred will be selected as poster presentations, but approximately 60 are selected to actually be delivered live on a podium. So those are considered the top 60 papers, and of those 60 studies or papers, 3 of them are given an award. So this is a very competitive award, and it is somewhat subjective, but nevertheless, this was just last year's annual meeting, and it speaks to the importance of this topic. And these are just forest plots basically showing that the anterior approach patients didn't have higher patient-reported outcomes in the short term, all the way out to 5 years post-op. So in summary, I would tell you that, you know, all modern approaches provide good results. This concept that one approach is significantly better than the other is very controversial at this point, and I would make the point that the surgeon should really choose the approach that works for them. Chances are, if they're good at what they do, they're going to do a good job, and the patient's going to be happy regardless of the approach. And don't let the surgical approach compromise the results. I showed you some pros of each approach as well as some cons of each approach, but for the most part, you don't want to do something that you're not comfortable with, so don't let the approach compromise your results. So with that, I will end. I thank everybody for their attention, and I'm happy to take any questions.
Thanks very much, Dr. Huddleston. That's just so much information and so much to think about. We have some questions from the viewers, and I'll send them off to you. I'll read them to you. The first one is, please, what can you tell us about 3D printers and their use for hip replacement?
Yeah, so 3D printing is a nice alternative to traditional manufacturing methods. It's cheaper and faster, and we have implants that are 3D printed now for sure. And anytime we change something, the first thing we want to do is make sure that we didn't do anything bad, and we're not having any problems with any of the 3D printed implants. So we will see more of them on the market. That's not something the patient's going to be able to distinguish. That's not necessarily something that the surgeon can take it out of a box and distinguish. But there is more and more 3D printing going on all the time. And due to the fact that it's less expensive and faster than traditional methods, we're embracing that.
Wow, great, thanks. Another question, is anterior better or worse than posterior for arthritis-directed operations rather than broken hip operations?
Yeah, so everything we just talked about was geared towards hip replacement surgery. So the most common reason why we do hip replacements is for osteoarthritis. When we get into hip fractures, there are many different types, and they get different treatments. Some hip fractures get treated with a hip replacement. So if you have a femoral neck fracture that's displaced and you get a total hip replacement, I would not expect there to be any difference in terms of the risk benefit or pros and cons analysis for approach compared to a patient with osteoarthritis. But that's only for displaced femoral neck fractures. If you have a subtrochanteric femur fracture, that's not going to get a hip replacement. If you have an intertrochanteric hip fracture, that's going to be treated usually with plates and screws and not hip replacement. So it really would be only femoral neck fracture that's treated with a hip replacement, and I would tell you it's a wash. But the same factors that would affect somebody having a hip replacement for osteoarthritis would be relevant for those patients who have a femoral neck fracture getting a hip replacement.
Great, thank you. This questioner is asking, how can you tell if you have a hip problem? After walking a mile or two, I have a very slight pain in my right hip and knee.
If it's consistent and it's troubling to you, certainly to the point where you have to modify your activities or take pain medicine for it, I would go ahead and make an appointment to see a hip or knee doctor. Fortunately, most of us who do hips do knees as well. So.
Okay, great. Here's one. Do you ever do hip replacement due to osteoarthritis on an otherwise healthy 95-year-old?
Yeah, so when we're deciding on whether you're safe to have the operation or not, we really focus on what we refer to as your physiologic age, not your chronologic age. So we have 95-year-olds who are more fit and whose hearts and lungs are in better shape than some 50-year-olds. So age itself is not going to be something that disqualifies you from the operation. I've done a hip replacement in a 99-year-old before, albeit with some trepidation, but everything went great and the patient was grateful that they did it. So the short answer is no. Being 95, especially if your heart and lungs are in good shape, you would likely be a candidate for hip replacement.
Oh, that's good news. What's your opinion on total hip replacement versus hip resurfacing in terms of resuming high impact sports activities like tennis?
Yeah, so most hip surgeons will tell you with a hip replacement, you are free to play doubles, but they wouldn't necessarily support you playing singles. That's not necessarily uniformly adopted, but that's generally been the dogma. Surface replacement is now down to much less than 1% of the market in the United States. It was higher than that in sort of the mid-2000s, but there were some significant problems with the bearing couple where it is metal on metal. And if the socket wasn't put in the exact correct position, you had accelerated rates of wear and big problems associated with that. So surface replacement has really fallen out of favor. In general, patients who have a surface replacement tend to want to be more active than a hip replacement. There are patients who have hip replacements that run marathons. I saw one in the office this morning. It kind of makes me cringe. So there is a chance you could be more active with a surface replacement in theory, but I don't know that we have enough data to say that that is actually a safe thing to do.
Okay, we have two more and we're just about out of time, and these two will be the last two. Does one have to sleep only on their back post hip replacement?
No, so we recommend folks to sleep on their back if they can, mainly because we don't want them putting any undue pressure on their incision. But once the incision's healed, you're free to sleep in any position that you want to. Many patients won't feel comfortable if you have a lateral or a posterior approach lying with the operated side up in the air without putting a pillow between their knees, because the position of the hip would be such that it's really stretching those tissues where the incision is, and that's a little bit uncomfortable. So that's one thing that we recommend, is to just use a regular pillow between your knees if you're having trouble. But generally after the incision heals, you're free to sleep in whatever position you would like to.
Okay, thank you. And this is our last question. This writer wants to hear more about the criteria that you use to decide if it's time to get a hip replacement.
Yeah, so just like most things in orthopedics, we try to optimize your non-operative treatment options before we suggest any surgical options. So for hip replacement, unfortunately, our armamentarium is a bit limited. So we have activity modifications, i.e. do activities that are not as high impact. The amount of pain that one has in their hip from osteoarthritis is generally proportional to the amount of force that goes through your hips. So higher impact activities like running are generally going to cause you more pain compared to something that's lower impact like swimming or the elliptical trainer. And so that is a major consideration after the operation. Once you've sort of optimized your activities and you're still having trouble, the next thing that we use are anti-inflammatories and Tylenol. And anti-inflammatories are generally Aleve and ibuprofen, are the mainstays of what we recommend. Tylenol works, but it usually takes a few days of taking it regularly to work. And most folks will say that it's not effective as non-steroidal anti-inflammatory drugs like ibuprofen or Aleve. There are others that we use, things like gabapentin and opioids we really don't recommend because of the problems associated with opioids in terms of adverse events and addiction potential. So we have activity modification, we have medications. A cane actually helps quite a bit if you use a cane in the opposite hand that your hip hurts in. That's been shown to reduce the force through your hip by approximately 30%. And that reduction usually translates to an improvement in pain. And then the other thing that we have to use that we don't use a whole lot are going to be intra-articular injections. So we do image guided, i.e. using ultrasound or fluoroscopy to inject either cortisone or a synthetic variant of your body's native lubricating fluid into your hip joint. And those are Band-Aids. They usually will help for a while, but eventually their effects are going to wear off. So we have activity modification, pain medication, injections. That's essentially it for our non-operative armamentarium. After that, then you're going to start talking hip replacement. And to get a hip replacement, at least for me, you have to have enough objective disease that I know you will get better afterwards. And then you need to show us that you have enough functional disability and really would benefit from the operation. And then perhaps the most important part is that the patient really needs to be psychologically ready to go through the operation. This is a major event in your life. I like to say you get one good bite at the apple. If it's done well, you're probably not going to have any trouble with your hip ever again. There's not many things that we can say that with such confidence in. So you need to be ready to dedicate the time to listen to what we have to tell you and to heal appropriately afterwards. So that's kind of the continuum of care. At the end of the day, you're going to have to exhaust these non-operative options before you would be a candidate for a total hip arthroplasty.
Well, I think this concludes today's talk, and I want to thank you, Dr. Huddleston, for joining us and for sharing so much information. There's a lot for people to think about, and as many people know, we have these videos will be up on the Stanford YouTube channel, so you can go back and watch it again, and you can also refer your friends to it if they have questions about hip replacement surgery. Thank you very much for joining us, and have a good afternoon. Bye-bye. Thanks, Dr. Huddleston.
Thanks, Nora. Thank you.